but also asthma, severe dyskinesia, immune deficiency, bronchiectasis disease, cystic fibrosis, alpha-1 antitrypsin deficiency. All these diseases result in two important changes of the airway, which is thickening of the wall and dilatation of the airway, often defined as bronchiectasis. See over here, the wall thickening is due to inflammation, but also to mucus adhered to the wall. Here you see an example of an airway, a small airway without cartilage that has a lot of infiltrate. The wall is thickened and the lumen is obstructed because the mucosal, the inner layer of the inside the smooth muscle, has to go somewhere. So it's folded in the lumen. There is almost no lumen left and there is debris or mucus in the lumen. The most important geometrical changes are located in the small airways. They're thickened, they're abnormal, but it doesn't right away result in symptoms for a patient that they can notice, because again, this large cross-sectional area. Lung disease is the loss of alveoli, of the parenchyma. So this parenchyma holds open the airway. It stretches the airway like this. So here you can see the histology of a normal parenchyma, and you see all those attachments to the, in this case, a quite big airway. So throughout the bronchial tree, in the lungs, there is interaction between the lung parenchyma and the airway. You have learned this, but this is physiology and why somebody with this lung disease gets obstruction. So to exhale, so elastic recoil and forced expiration. The alveoli, but then due to loss of, due to resistance, you lose pressure, and then you get to a point where the pressure outside the airway is larger than inside the airway, and you compress the airway and you get obstruction. Diameter and the wall thickness, and also we can measure the ratio between the total wall area and as a fraction of the total airway area. Because I wanted to mention that for each branch, every millimeter, it executes 72 measurements. So there are really hundreds of measurements for a single small airway.